Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based out of DRC. I will now hand over the briefing to Dr. Ngashi to start the session. The weekly briefing focuses on health emergencies across the continent. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, colleagues, depending on which part of the world you are in right now. I would like to welcome all of you to this week's press briefing, which is our commitment to you to keep you updated on the situation of outbreaks on the African continent. Dare to say that this press briefing is taking place at a very interesting moment, as today we are also attending the WHO Emergency Advisory Group that is reviewing the situation of Mpox and advise the Director General of WHO whether they can lift up the emergency declaration or continue it. At the same time, also yesterday, there was a very high-level meeting of heads of state that was also looking at the situation of cholera on the African continent. I think those are some of the main highlights that we'd like to give you a bit of the details of where we stand now with outbreaks on the continent. With that, Director, perhaps we can now go into the PowerPoint presentation. Thank you. Now, I would like to take you through the update on where we stand with Mpox and other health emergencies on the continent. First of all, let me just start with presenting apologies from the Director General, who could not make it today because of other unexpected issues. Next. Now, let me start with where I just said that yesterday, there was a high-level meeting that was organized by the President of Zambia in his capacity as the African Union champion on cholera at the request of Africa CDC to really bring all the heads of state in the 20 most affected countries to reflect on the situation of cholera and try to chart a new response, I think more bold response to help member states control this outbreak and also accelerate the agenda toward elimination by 2030. The outcome of that meeting is a call to action. I think that is going to be released today, where there is really both action that takes about the leadership of the president themselves to the mobilization of adequate financial resources to the coordination of the response on the continent, even the importance of really pushing the local manufacturing of some of the cholera essential commodities like oral vaccine and also the IV fluid on the African continent. I think we'll be able to share that by the end of the day. Next. In addition to that, the Director General also attended the Mo Ibrahim Foundation week event in Egypt, that to reflect on the health financing for development on the African continent. I think it was also an opportunity for him to share the Africa CDC health financing strategy, which has already been shared with many of you in the past. Next. The DG continued his engagement. He attended the election of the new president of the African Development Bank in Abidjan. It's an opportunity to also interact with our leaders, including the president of Mauritania, President Mohamed Ould Sheikh El Ghazouani, but also the incoming president, who is Sidi, just to discuss also how already from the start we can chart a new pathway for the collaboration between Africa CDC and the African Development Bank in particular, but within the broader context of the public health agenda that Africa CDC is pushing on the African continent. Next. Now, that is just a little bit on the DG's engagement and some of the major events happening on the continent. But now, coming to the Mpox situation in Africa, I think we have reached 141,000 cases reported, over 35,000 confirmed, of which 1,793 dead among the suspected and 188 among the confirmed, giving us a case fatality rate of 1.3 on the suspected and 0.5 on the confirmed. But the most important is to say that now, if we look at the numbers on the confirmed cases only, that by week 21, which is the end of May, I think, we had already reached almost 100% of all the cases that were confirmed in 2024. It just shows that this year, I think the numbers are much higher than they were last year. Similarly, on the suspected cases, last year we ended with over 77,000, and this year we have already reached over 64,000 cases. It just shows that the situation is not yet completely under control, that if anything, we should be worried of a worsening situation, and it's come to the number of cases that are being reported, and also the numbers that are confirmed. But when we look at week 21, there were 2,705 cases that were reported compared to 2,844 the week before. The number of confirmed cases also stood at 932 compared to 995 the week before. And the number of deaths among suspected cases, 5 compared to 14 the week before, and deaths among confirmed cases, 2 compared to 7 the week before. That means overall, on all those 4 indicators, we see a declining trend. But it's also important to say that we are more concerned about what is happening in Sierra Leone. As you can see, the last comer that is also showing very high numbers, accounting for 53% of new confirmed cases during week 21, and now driving the increasing trend that we see on the Mpox outbreak over the last 6 weeks on the continent. Next. But we also wanted us to zoom in on the 4 countries that represent 94% of all confirmed cases during week 21, which include DRC, Uganda, Sierra Leone, and Burundi. I think from here, we tried to dive into each of these countries, in addition to the country that recently reported cases that had not reported before. Let's move on next. Let me start with Ethiopia. As of on May 26, the Minister of Health of Ethiopia reported the first cases of Mpox. But as of 4th of June, just about 9 days, 40 cases have been notified, of which 17 confirmed and 1 death. And when you look at the performance on the laboratory side, we have testing coverage standing at 100%, and the testing rate at 100%, and the test positivity rate at 43%. I think the most important is to say that Ethiopia has already reported 1 death on 31 of March 2025, which is an infant. But the contact tracing is ongoing, and the isolation has already been established. But most important to say is that there are 2 regions that have been affected out of the 14 regions of Ethiopia. And you can even see the right locations of the cases on the map, which is on the left. I think we've put on the red circles to indicate exactly where the cases are. You can see that the first cases started in Oromia region, very close to the Kenya border, but there are also new sites that have also reported cases inside the country. Next. We've also reported cases happening in Togo since May 16. The Minister of Health also declared the Mpox outbreak in that country. As of in week 21, there were 22 cases that were notified compared to only 3 cases the week before. There were 5 confirmed cases compared to 3 cases the week before. No deaths yet reported from Togo. But what we know from the sequencing is that it is clade 2B has been identified in Togo, the same that is also striking in Sierra Leone. And on the coverage side, on the testing side, we have 100% coverage and 100% testing rate and 23% test positivity rate, which is good performance on the diagnostic side. But it's also important to mention that Togo is also doing very well on surveillance side with 181 contacts that have been listed and being followed up. If you look at that for 8 confirmed cases, that gives you more than 20 contacts per each confirmed case, which means that it's really an indicator of good performance of surveillance. And the IMST is working closely with them, supporting the areas of surveillance, IPC, laboratory, even case management as well. Next. In Malawi, also, there are 145 suspected cases that have been reported so far, 19 confirmed, no deaths that have been reported yet. All those cases are from 3 of the 28 districts of Malawi. But looking at week 22, there were 122 cases that were notified, compared to 23 on week 19. 4 confirmed cases compared to 6 on week 19, and no deaths yet. But also the description of the confirmed cases, children make about 15% of the cases. Males still dominate with about 90% of all the cases. And Malawi is experiencing clade 1B that was also identified in the neighboring Zambia. But on the testing side, testing coverage 100%, testing rate 100% with a test positivity rate of 13%. They are to say that about 249 contacts that have been identified, and all of them are being followed up out of the 19 confirmed cases. That also gives us an average of about 15 contacts per confirmed case, which is a good performance of the surveillance. But IMS is also supporting. There's a mission that is also planned for Malawi to try and really push our new strategy to be bold right at the start to try and control these outbreaks once they start. Next. In Sierra Leone, I think this is the country most concerning right now. There have been 4,032 suspected cases reported so far, 3,140 that have been confirmed, but with 15 deaths, giving us a case fatality of almost 0.5%, which is very good in terms of the performance on the case fatality rate. But just to say that all the 16 districts of Sierra Leone are now reporting cases. Now, on week 21, there were 531 notified cases compared to 684 the week before. There were 492 confirmed cases compared to 603 the week before. There was 1 confirmed death compared to 3 the week before. That when you look at that, we see a decline, at least when you compare with those 2 weeks, the week 20 and week 21. Now, on the confirmed cases, I think 68% of them are male. There are very few children that only make 2.7%, as it is the case of Togo that I reported before. It is clade 2B that has been identified in Sierra Leone. On the testing side, 95% testing coverage rate, a testing rate of 100%. But what is of really great concern is the test positivity rate, which is at 93% overall for the entire country. And there are 7 districts that report 100% positivity rate. What does that mean is that people come themselves to consult in the health facilities, and all those that come, they come already at advanced stage that almost all of them test positive. It's just a reflection that the surveillance is primarily passive surveillance. I think that's already a major weakness, that more effort are really needed in Sierra Leone to reactivate the active surveillance. Now, they started at the beginning with what they called Find Them All, using community health workers to help in surveillance, but that program has stopped because of difficulties in funding. But just to say that 91% of cases are concentrated in 3 districts, Western area urban, Western area rural, and Bombali. And this is a country where we see the high population density and tourism, which is one of the factors driving the spread of the outbreak. And there are also cases that are being reported among students. And I think on the contact side, it's also one of the weaknesses that you expect to see in a passive surveillance. It's about 4,499 contacts that have been identified out of the 3,140 confirmed cases. That gives us a ratio close to 1-to-1, knowing that really surveillance remains one of the major weaknesses in the Sierra Leone Mpox response. Next. In DRC, where we have the highest numbers, I think 107 suspected cases, 21,000 almost confirmed cases, with 1,793 deaths among suspected and 111 among confirmed, giving us case fatality rate of 1.7% among the suspected and 0.5% among the confirmed. Right now, it's 25 out of 26 provinces of the DRC that are being affected. But when you look at the overall trend on the graph, I think this is a country that is showing stabilization of the outbreak. But in week 21, there were 1,813 cases that were notified compared to 1,748. There were 213 cases confirmed compared to 182 the week before. That means that at least in comparison of those 2 weeks, we see still an upward trend in week 21. But when you look at the confirmed cases, males make 54% of all the cases, children account for 36%, and there's a co-circulation of clade 1A and clade 1B. On the testing, I think the major weakness in DRC has always been the testing coverage, which stands at 27% now. It makes it very difficult really to interpret the stabilization that we are seeing, because at least 3 out of 4 cases remain untested out there, meaning that what we are dealing with is just a tip of the iceberg as well. On the testing rate, laboratories are performing very well. I think all the samples brought to the laboratory are tested. That's in the testing rate of 100%. The positivity rate now stands at 43%. Now, important to say that in the DRC, the Kivus were the epicenter of the epidemic. That is on the eastern part of it that was also affected by insecurity. We are seeing the stabilization of cases in the Kivus, which is really good news, and the vaccination is ongoing right now. And that's also an area that we have deployed epidemiologists to be able to support the intensification phase of the response. Now, currently, there are 6 provinces that account for 97.5% of all cases reported in week 21. That is North Kivu, Kinshasa, Sud Kivu, Tanganyika, Chuapa, and Equateur. That will be also the provinces that have been prioritized for the intensification of the response in the DRC. Next. Now, on the vaccine delivery, I think some good progress. I think that can be reported on that side. I think there are about 2.9 doses that have been released and shipped to the countries, and 11 countries that have received vaccines, 7 that are vaccinating right now, more than 726 doses administered, and of which 22% of children. That's mainly in the DRC. I think the only country that is now vaccinating children below 18 years. Sierra Leone and Zambia were approved during the fourth round of allocation to receive 51,160 doses of Mpox. And there are also new arrivals, I think, in the DRC, 100,000 doses from France, 1.5 million doses from Japan, that is the LC16, and also 20,000 doses from UAE as part of the bilateral agreement between DRC and UAE. Next. Now, that is it for Mpox. I would like that to switch a little bit on cholera. To say that yesterday, the president of Zambia, as I said in my intro, convened the meeting with 10 heads of state, the 20 member states that were invited because there are those that are affected by cholera, 10 member states that were represented at the level of the president or the vice president, and another 10 members that were represented at the level of the ministers. The situation that they reviewed is the number of cases of cholera. As you can see, between 2022 and 2025, the situation has really been on the upward trend. Already in May 2025, which represents just 5 months into 25, we have already exceeded half of all the cases that were reported in 2024. They're saying that the situation is still of great concern and it continued really unabated. But also important to say that for this year in 2025, in the month of May, accounted for 60% of all cases. I think from January to May. Africa accounted for 60% of all cases that are reported globally, 93.5% of all deaths that are reported. But when you compare also the year 2024 and 2025 within Africa itself, we see that from January to May 2025, there have been a 24% increase in the number of cases and 52% in the number of deaths. That's showing it is a situation which is really deteriorating. That's why that meeting was convened yesterday. Next. When we try to zoom into the 4 most affected countries, that is Angola, DRC, Sudan, and South Sudan, these 4 account for 85% of all cases reported in Africa and 92% of all deaths reported on the continent. And the children make a significant proportion of the burden, accounting for up to 47% of cases and 37% of deaths. But if you look at the countries themselves, South Sudan is the one reporting the highest number of cases with 48,828 cases and 908 deaths. It is followed by DRC with 25,520 cases and 557 deaths, and Angola with 21,000 cases and 630 deaths, and then Sudan with 13,743 cases and 296 deaths. But the most concerning is also the fact that in all 4 countries, the case fatality rate is high. You know, the expected is less than 1%, but all of them are close to 2% and above. South Sudan is at 1.9%, DRC is 2.1%, Sudan is 2.5%, and Angola is at 3%. That is why it is of so great concern that this is really the time to accelerate the response and change the current trend. Next. We also looked at the key factors that drive the cholera outbreaks on the continent. I think some of the main challenges include the weak interministerial coordination. I think there's a really fragmentation of the response in countries, with the health sector still trying to lead, yet everybody knows that this is a multi-sectoral response that also expect great contribution and leadership from the water and sanitation sector, which has been weak. And then secondly, it's also a reflection of the many years of underinvestment in wash infrastructure, even complicated now when you look at the fact that over the last 4 to 5 years, health financing has been declining in Africa. There is also observation of the major gaps in cross-border surveillance, which explain why I think there's that spillover of cases from one country to another. If you looked at the map, they're all concentrated in neighboring countries. At the same time, this is happening in the context of a number of important risk drivers, such as the conflict that are happening in South Sudan, in Eastern DRC, natural disasters, and the increasing population movement across those countries. And finally is on the commodity shortages, that right now we have gaps in the availability of oral cholera vaccines and also essential supplies. But we just wanted also to show some of the key indicators on the water and sanitation, to highlight the importance of really stepping up investment in this sector. When you look at the percentage of the population which has got no access to safe water, it ranges from 35% in Sudan to 65% in the DRC. If you look at the proportion of the population with no basic sanitation, it ranges from 48% in Angola to 84% in DRC and South Sudan. If you look at the proportion of the population still practicing open defecation today, it ranges from 12% in the DRC to 60% in South Sudan. And in some rural areas like in South Sudan, we reach up to 73% of people that are really defecating in the open. I think that's also where we can understand the vulnerability of these populations to cholera. We also looked at the percentage of schools which have got no hand washing facilities for our children, which ranges from 57% in Sudan up to 90% of South Sudan. I think those are some of the factors of vulnerability which explain why this response should no longer be a health response, which should be a multi-sectoral response that's also seen a greater role of the wash sector into it. Next. Now, looking at the availability of essential cholera supplies that we spoke about, one of the things that came out of the discussion is that when you look at the global oral cholera vaccine production capacity in 2024, it is just 37 to 50 million doses that could have been produced, and all of it from one single manufacturer globally. But when you look at the global needs, the same year they were estimated at 80 million doses, which was far above the production capacity. We look at the African needs alone, 43 million, meaning that Africa could actually use the entire global production, but Africa only received 26 million doses because of the fact that these doses had to be distributed also to other regions. I think this is the reason why now there's this greater push that came from Africa CDC, and now also it came from the head of state, and Africa CDC has taken that as a priority to really push the local manufacturing or some of these medical countermeasures on the continent. There are three manufacturers in Africa that really have the capacity to do so. And also the level of investment that is required is only 150 million, in financing, in addition to ensuring that through the Africa Port Procurement Mechanism, we can also secure the pulled demand to be able to create the volumes important to sustain the market. Just to say that these are doables. 150 million is not an insurmountable amount that really African countries can really afford to invest to be able to contribute to making these life-saving vaccines available to the African people. And some of those manufacturers that are ready include BioVac in South Africa, DEC Vaccines in Ghana, and also the Zambia manufacturing plant, which has just also been established there with a plan to produce oral cholera vaccines in the country. Next. Now, some of the recommendations that came out of the head of state meeting is one is that it is time to elevate the oversight of the cholera response to the presidential level, so that then countries establish a presidential task force that can bring in all the key sectors into a multi-sectoral action, and also allocate the necessary resources, especially now that ODA is going down, that put more of the domestic resources and ensure accountability across the responsible ministries. Now, the second recommendation is to learn from the experience of the Mpox coordination through the continental IMST and expand the mandate of the IMST to coordinate a continental response to cholera. The third recommendation is to really increase the investment in the water sector to ensure that the infrastructure is really prioritized, especially in the high-risk areas, through this multi-sectoral response plans. The fourth recommendation is also to increase the availability of critical supplies. This is including both the stockpile, but also the local manufacturing. The fifth recommendation is really focused on those areas of insecurity like the Eastern DRC and Sudan, to be able to guarantee some humanitarian access, to create humanitarian security corridors that can allow an uninterrupted delivery of services in those contexts. And finally, to ensure that no member state really mobilize reliable financing to be able to sustain the response to cholera in a way that really supports already the Africa CDC health financing strategy, which has prioritized three different areas: increasing domestic resources, looking at innovative financing, but also at the same time bringing the private sector into blended finance that can then mobilize the resources needed to build the health infrastructure and support the cholera responses in the countries. Now, next. I think we really wanted this week to focus on those two conditions. As you might have heard, also there's an outbreak of chikungunya, which is in Kenya right now. I think perhaps next week, if all goes well, we'll be able to also include that. We didn't want this presentation to be too long because the new development of cholera was just important for us to report on that to you a bit more details. But in summary, what we can say that we see this high-level commitment from the African head of state really to accelerate the response to cholera, also bring all the key ministries together, including the Minister of Health, the Ministries of Water and Sanitation, and also the Ministries of Finance, because of the key role that these three ministries have to play, in addition to all the other ministries also that have to a contribution to make. And what came out yesterday is that really this is time to act. Now is the time to act to control cholera and really help the countries move toward the goal of elimination by 2030. We are particularly proud for the commitment that the head of state made they endorsed a call to action, which is going to be released today, which summarizes the key areas of the action moving forward, both for the government but also for Africa CDC as the public health organ of the African Union. Just to also say that the emergency coordination group on Mpox met already to discuss, what is now the current path for Mpox, whether to lift or not lift the public health emergency of continental security. The meeting took place on the 30th of May. By tomorrow, I think the report of that meeting will be released. But it also happens, as I briefed before, that WHO Emergency Committee is also meeting today. We'll be able to look at the two recommendations from the two groups, hopefully this week. And just to say, as a way of concluding, that on the Mpox front, there is still a lot of work to be done. Sierra Leone is still getting of greater concern. We still have new countries like Togo and Ethiopia that need to be supported. Just to say that really there's no room for complacency yet. We are seeing good development in the countries that were of great concern before, DRC, Uganda, Burundi. We are seeing stabilization. But these new countries are just of great concern, but also an opportunity for us to draw lessons from those that have stabilized the epidemic to also apply them to be able to achieve even much faster than we did in other countries. And secondly, is the cholera outbreak, which is also really taking that priority here on the continent, that starting from next week we'll be also reporting to you how much progress we are making on that front as well. Director, I would like to stop there and open up for discussions, comments from the participants. Over to you.
Thank you, Dr. Ngashi. Let's cross over to the floor. We have Esther Nakazi, a science journalist based in Uganda. Esther, you have the floor.
Thank you very much, Margaret, and thank you, Dr. Ngashi. Dr. Ngashi, you said that you are going to use the IMST system or plan for controlling cholera, just like you did Mpox. Does that mean you're going to link up with WHO and come up with the Continental 2.0 plan like you did for Mpox? Or how exactly are you doing this in terms of coordinating it and putting it on a continental level? Thank you so much.
Thank you, Esther. Let's take the next one before Dr. Ngashi comes in. Paul from the Lancet, you have the floor.
Yes, thank you. My first question has to do with, in his opening speech at the meeting, WHO DG Dr. Tedros highlighted that Africa CDC is participating and they are working together. So I'm curious to know what's the recommendation of Africa CDC is with WHO. And I know you said the report of the African committee would also soon be released. So what do you think the Africa CDC is recommending? And if we are extending this emergency declaration, in your presentation today, you highlighted that cases continue to grow and the wide testing gap is still very, very wide. Are you suggesting that we should continue, the response should still continue the way it is, or how are we trying, what is the difference that we can bring about to actually make significant change, and we can start seeing the impact of these emergency declarations and outcomes in the various African countries? Thank you very much.
Thank you, Paul. Over to you, Dr. Ngashi.
Yes, thank you very much, Esther, and thanks, Paul, for those very good questions. I think on the face regarding Esther's question about how do we plan to move with this new IMS on cholera with WHO, I think the recommendation from the head of state was very clear. They are building on this model here, where Africa CDC and WHO are co-leading the continental response to the IMST outbreak response. It's exactly the same thing that is being recommended also for WHO and Africa CDC to co-lead the IMST on cholera. I think this is the model that has shown that it improves coordination, it improves synergy. It becomes even more important when you look at what is happening globally with the health financing that is declining, that this is really time for more efficiencies. And that it's like we had already anticipated this as we saw it coming, that we don't need multiple structures of the organizations, but really pulling all those structures into one single structure and building complementarity based on the comparative advantages is the best way to go. But just also to say that the IMST is not only limited to WHO, although Africa CDC and WHO lead, it also includes all the other partners. We have about 28 different partners that are seated, in the IMST Mpox that are working together. The same thing, even the preparation for the meeting. I think there were other partners that were there. We had Gavi there to address issues related to vaccines. We had UNICEF there to address issues related to water and sanitation. It's exactly the same model under the co-leadership of WHO and Africa CDC, but all partners joining hands into one plan, one team, one budget, and one M&E. Now, for Paul, I don't want to preempt the recommendation that are coming from the ECG members, because I'm not a member myself. No, I'm in the WHO emergency committee, but I'm not in the Africa CDC. But what I can say is that when you look at the data, it shows that we are not yet out of the woods. We are not yet. Remember the figures that we presented in terms of just the numbers of cases. Already now we have the total almost 100. We are getting to 100% of all the cases in 2024 that are now reported over the first 5 months. If you look at the spread of the outbreak within Africa and beyond Africa, you see that we've seen clade 1B also spreading and clade 2B also spreading. That means that we have now 2B and 1B all spreading in Africa, 2B going into Togo and 1B going into Malawi. It's that the spread is still there. I think the risk of spillover still continues. And we have even cases that are reported outside of Africa. There was that case that was reported in China, also 1B going into China. That to say that on all those grounds, it's really clear that we are not yet out of the woods. Even the strength of the response itself. I just spoke about Sierra Leone. You see that really surveillance is very weak in Sierra Leone. It is still passive surveillance, which explains that a test positivity rate, which is above 90%, with about 7 districts that have 100% positivity rate. It tells you that the active surveillance, which is really important for us to get this outbreak under control, is not yet there. We spoke about the DRC with the testing capacity at 27%. When you look at all those elements, is that the response capacity still has serious weaknesses. The cases are still increasing. The risk, the global risk, and also the risk to other countries is too high. I think I would imagine that these are important elements that need to be considered in the decision to lift or not lift. As I said, I'm a member of the WHO emergency group, which is meeting right now. After this, I'll go back and join the group. I cannot preempt, I think, what is coming, but we know that by tomorrow, we know exactly what are the recommendations that are coming out of those two groups.
Okay, thank you very much. Let's take the next two questions from the chat group. We have Pamela Das is a senior executive editor from The Lancet. The questions are, what is responsible for the new surge of Mpox in Sierra Leone? And to what extent can health systems cope? And what prevention and control measures are being implemented nationally and regionally? And what are the major challenges to responding? It's a mouthful. Did you get it, Dr. Ngashi? I can repeat.
Yeah, please repeat. Yeah, Director, can you repeat? Can you repeat, Director?
Yes, we lost you a bit. So there's a couple of questions on the surge of Mpox in Sierra Leone. So the questions are, to what extent can the health systems cope in Sierra Leone, and what prevention and control measures are being implemented nationally and regionally? And then what are the major challenges to responding? I think you can take those ones first.
Yes. Let me just take first. The questions are what can explain the spread of Mpox in Sierra Leone? I think, as you can see, that Sierra Leone neighbors were affected before. Liberia, we had cases in Liberia, we had cases in Guinea, and also the weaknesses of the cross-border surveillance explains why this spread continues from one country, continues spreading to other countries. Now, the major challenge is that in terms of the prevention and control measures that are being used, they're the same ones. I think the same traditional measures that are being used. Number one, just make sure that all the cases through surveillance are identified, tested for confirmation, and isolated to interrupt the transmission. That is one. And two, make sure that the communities are educated, have the information to be able to apply all the preventive measures related to good hygiene, especially avoiding contact with anyone that is symptomatic. Number three, identify all those that have been exposed to the virus and educate them on prevention, but most importantly, monitor them closely so that if they do develop symptoms, then they can be isolated to also stop the transmission. In addition to that, if vaccines are already in the country, this is a priority group because they have been exposed, vaccinate them within the 4 days of exposure to help them also avoid developing the disease. I think those are the traditional measures. And for all those that are sick, confirmed positive and sick, then you isolate them and give them a comprehensive treatment that includes clinical care, includes psychosocial support, and also it includes also the nutritional support that there to make sure that you really reduce the case fatality rate as much as possible. I think those are the measures. But the main challenges in Sierra Leone is that one, for the surveillance to work, you need the active surveillance, community-based surveillance through community health workers that can then be doing, home visits to be able to educate people, show them the symptoms of the disease, and then identify all those that have symptoms to get them into the, to the surveillance team to be assessed if they have the disease, then to be sample tested to confirm if they, and then manage them properly. In Sierra Leone, one of the major challenges is that they started at the beginning with this program they called Find Them All, which was using community health workers. For lack of funding, they have stopped that because they don't have funding anymore to continue that program. As a result, the surveillance system has collapsed. And now they've gone back to passive surveillance, meaning they're just waiting for people that develop the disease and become advanced in the disease who come themselves to consult normally at the health facility. That is the point then they identify them. I think that's the reason why we reported that 100% positivity rate. I think among the challenges, really the leadership is very much committed. We need to give them credit to that. They are very much committed to the response. One is the weak health systems, I think, which is not the result of Mpox, but Mpox is just thriving on that weak health system, which explains the reason why the surveillance system is weak, the data system is weak, they don't have enough healthcare workers. It's a weak health system to start with. Now, worsened also by the fact that we are in the financial financial crisis now with declining development assistance, that also comes at this time and then worsens then the situation in Sierra Leone. They don't have funding to be able to then strengthen the system to be able to respond adequately. I think those are some of the things that explain the reason why the situation is what it is in Sierra Leone. But in terms of the response, the IMST is really working with all the partners to start from the beginning. One is that we are mobilizing all the resources that are needed to be able to mount a strong response. Financing is one thing that we're working. We are working on getting them the vaccines, as announced, that we just allocated again 50,000 doses of vaccines to Sierra Leone, to be able to vaccinate all those that are exposed. We are also sending the technical expertise to be able to beef up the complement of epidemiologists in the country. And then finally, we'll be working with them to really support the reactivation of the Find Them All, which is community health workers, to be able to, again, push the active surveillance. Those are some of the areas that we are supporting them. With the community response, we also want to push the IPC, the Infection Prevention and Control, because of the fact that you remember at the end, the number of cases that we identified in Sierra Leone exceeded the capacity to hospitalize them. And therefore, the care of people with Mpox in Sierra Leone combines both those that are advanced, isolated in the health facilities, and those that still remain are taken care of at home. Taking care of at home requires also community health workers and also the IPC supply to be able to prevent further spread of the outbreak. That's the kind of support that we are providing to Sierra Leone.
Thank you, Dr. Ngashi. Let's move back to the floor. We have Kemo Cham from Mano Reporters. Kemo, you have the floor. Over to you.
We'll go to the delegation at the border.
Hello. Thank you.
That was how
Hello, Cam. We can't hear you. There's a lot of background noise.
Hello, if you can hear me. I just wanted to ask Dr. Ngashi. He mentioned cross-border infection. I would like to know how significant cross-border infection has been within West Africa, and particularly between Sierra Leone and neighbors, as far as data you have are concerned.
Thank you, Kemo. Let's take the next question. We have Edith Mutethia from China Daily Reporter. The question is, how is Africa CDC promoting a multi-sectoral approach involving various stakeholders to combat cholera? And then what lessons have been learned from the current outbreaks, and how are they shaping future preparedness and response plans for infectious diseases? Over to you, Dr. Ngashi.
Yes, I think just to say that cross-border surveillance is one of the major weaknesses on the continent. It is an area that Africa CDC has invested so much, but at the same time also, which still show that there is a lot to be done in that area. You can see that this outbreak, whether in West Africa that we are now talking about here, the question is asking West Africa or East Africa, it always starts from one place, and then from that place it starts now spreading to other countries. And there were even situations of cases, symptomatic cases moving from one country and crossing the border and being picked in another country. That shows that despite the fact that countries do have borders, but that surveillance element is something that needs to be strengthened. I'd like to invite Messi on the question about cross-border surveillance in West Africa, if you can make a comment on that.
Thank you. Thank you so much, Dr. Ngashi. Actually, Africa CDC has been doing quite a lot on cross-border surveillance in collaboration, definitely with other partners like IOM. But just to give you a snippet, that we've been seeing a number of outbreaks, not only Mpox, that really are showing that potential of cross-border. And we're seeing Lassa fever, where we have in multiple countries in West Africa being affected. We're also seeing cholera spreading across the borders in other countries, not only in West Africa, but also we're seeing that in Southern Africa and also in the eastern part of the continent. And at Africa CDC, we have a cross-border program, and we've actually been mobilizing the member states within the regions to build strong or robust mechanisms for information exchange. We've also been able to shape that space in bringing countries together to identify key indicators and key information parameters that are common across different countries, and they have actually agreed to share those information that's critical across several of them. And these are some of the areas that we intervene in. In addition, one of the things that we're also pushing for is for member states to have legal instruments that are binding across borders, where they can be able to really not only have this in paper, but again, affirm this kind of information sharing mechanism. Lastly, is also building the capacity for countries to be able to have robust data infrastructure, whereby information that are shared by their counterparts are also secured. And this is an approach that we're using to also ensure that countries are able to build trust amongst themselves, so that they know the information that they're sharing is also secured by their counterparts. At the IMST level, what we've been able to do in collaboration with IOM is to organize cross-border meetings, whereby countries are able to come together, the different districts across that share borders with within the across different countries, we're able to come together to identify the common challenges that they face. And one of those challenges was the fact that we don't really have legal crossing, or more or less gazetted crossings. And this actually shows that our borders are quite porous. So they were able to identify those key areas that they feel like there's high mobility across them, as well as key populations like the IDPs, refugee camps that require some sort of information sharing across borders. And this has actually helped in different countries to be able to, especially those affected, to be able to share information with their counterparts, and also do contact tracing across the borders. Over.
Thank you very much, Kiang. I think just on the other question from our colleague from China CDC about the multi-sectoral approach. If you look at the current response design in the countries, but also at IMST, you see that right from the start, we had realized that this response went beyond the health sector alone. If you look at surveillance, we use surveillance, the One Health approach to surveillance, to also bring in both environmental health, human health, and animal health, knowing that in many countries you still have a combination of the zoonotic soil with 1A, and then you have the 1B, which is human to human, that we really need to leave behind as a legacy to strengthen the system, a One Health approach to surveillance, which is extremely important. And secondly, that when we look at the infection prevention and control approach that we are using, you have the health sector, but at the same time, you also have the water and sanitation sector. Recognizing that everything that we talk about, hygiene is extremely important, access to clean water are important components when you talk about infection prevention and control. In the case management, we have the clinical case management. We also have psychosocial and mental support, and we do also have the food and nutrition support, meaning that you have health, you have water and sanitation, you have food, and then you have the education sector. All these are important sectors that all contribute to the Mpox response, to just explain why it is a multi-sector approach. The lessons we have learned are many. I think the most important ones are the one that, first of all, it is the unified continental coordination that has to be reflected both also at continental level, but also at national level and subnational level. That is extremely important as we move forward, that the coordination is really integrated to be able to optimize the contribution of all the key players. Secondly, data is really central. We also needed a unified data platform that can connect surveillance with laboratory, with case management, with vaccination. For the first time, we've worked with the University of Oslo now. We are working with the University of Oslo to be able to standardize that module, on emergency management that include the different pillars of the response. And this will remain for future outbreaks, that we don't suffer again on getting data the way that we have done. Thirdly, is that the community-based surveillance and the community response is not something that we can do ad hoc. That's the reason why we just completed a survey on community health workers on the continent. We have 1 million community health workers, in Africa right now. We would like to really train all these 1 million community health workers also in surveillance, so that they look at both development program, but also emergency preparedness and community-based surveillance, in particular, and also IPC, so that they become a resource that is mobilized in every outbreak to be able to support those components. And finally, is the importance of laboratory decentralization, that this whole issue of the cost of sample transportation is really a nightmare, because we had not done that. Then when USAID decided to stop its funding, we saw what happened in DRC and Uganda as well, because they were paying for the sample transportation. So what we decided is to decentralize laboratory capacity, so that every single district can test some of these pathogens locally. For the future, then some of those barriers and the delays in testing will be addressed for the future. I think those are just some of the lessons that will carry forward as a legacy of Mpox, and also to strengthen the resilience of our system.
Thank you, Dr. Ngashi. Let's take the last two questions. We have Paul, you have your hand up from the Lancet. Is that a new hand?
Yes, please. So very quick follow-up question. You mentioned the amount of vaccines that have been rolled out, and you mentioned that some countries that are reporting cases are still yet to roll out the vaccines, and we still have a wide gap between over 2 million doses received and just under 1 million distributed so far. So currently, what are the key factors delaying the rollout of these vaccines? I remember you mentioned some millions of dollars needed by UNICEF to get some vaccines. So I just want an update on the current bottlenecks for vaccine rollout on the continent.
Thank you, Paul. Let's take the last one before Dr. Ngashi comes in. We have Kate Lay from The Guardian, UK. The question is, can you tell us more about the Mpox vaccines in Sierra Leone? Are there issues with funding community health workers likely to hamper vaccine administration? Over to you, Dr. Ngashi.
Yeah, thank you very much. I think, Paul, the problem of vaccine is availability. I think that's the main problem right now. Remember that the second plan for the 6 months from March to August 2025 estimated that we needed at least 6.4 million doses of Mpox vaccines to be able to cover the target population in Africa. Right now, we only have visibility on 500,000 doses. And of those 500 doses, we have the doses that come from UNICEF, for which they are still mobilizing funding. So you understand, really, the visibility of vaccine availability is not guaranteed for now. That is the main challenge. It's not the ability of the countries to absorb and spend, it's just our capacity to mobilize enough vaccines to make available to them. And because of that, Another area that we're trying to explore, if member states can themselves buy those vaccines now that the external support is kind of going down. But the challenge is the price. It is $65 for one dose of vaccine. Now, can you imagine a country like, if a country is planning for the 6 million that we are talking about, 6.4 million, you multiply that by $65 each dose, you can see how much money is needed. I think that is one of the major bottleneck right now on vaccine. Reason why we are pushing for the local production of vaccines in Africa, so that in the future we can control not only the production but also the price to make them available to the largest population possible. Currently, the problem of vaccination in Sierra Leone, first of all, it is the quantity, but we provided first of all 58,000. They have absorbed that. We've now provided another 50,000. I think that is on the availability. We are making an effort, but it's not enough, as you can imagine. The main problem is the mobilizing more vaccines for Sierra Leone. I think that is where the main bottleneck is. Now, the second question is, will then the lack of community health workers impact vaccination? Of course, yes. But these are the people that go and mobilize communities and educate them and bring them for the vaccination. Now, without them, it will be kind of hard for the nurses and doctors themselves to be able to really mobilize the communities directly, knowing that there are not many and knowing that they're already overwhelmed with the care they have to provide in the health facilities. That's the reason why Africa CDC is really committed to go and really support them to bring back those community health workers to support not only the vaccination, but also the active surveillance and then the risk communication at community to ensure that the IPC, that community get the support from those community health workers, which is critical. Over to you, Director.
Yeah, so just one last question before we wrap up. This is Lisa, a news editor in the US. The question is, have scientists determined which Mpox clade is involved in Ethiopia's outbreak? Dr. Ngashi?
No, I think we haven't seen the data from Ethiopia, the pathogen sequencing of the Ethiopia Mpox virus. But given the fact that it is on the eastern part of the continent, there is a high likelihood for it to be clade 1b. But that is just likelihood. But we are still waiting to look at to see the result, what exactly it is. Most likely, perhaps next week, if we have it, we'll be able to announce that.
Thank you, Dr. Ngashi. And with that, we have come to the end of our briefing this week. I'll now hand over the floor back to you for your closing remarks. Over to you.
I would like, on behalf of the Continental Incident Management Support Team, to thank all of you really for this continued interest. It also encourages the IMST to know that we are accountable to you, to keep you updated on how the outbreaks are going on the continent. And we wish that this should be something that will maintain on a regular basis. And now we are expanding to also take on other outbreaks like cholera, which might be coming our way very soon. But it is very important that the future of Mpox, or our response to Mpox in the current context, will very much rely on the outcome of the ongoing emergency consultative meetings. I think the one taking place today from WHO, and also the outcome of the Africa CDC emergency consultative group. I think as soon as we hope that by next week we'll get the outcome from those two meetings, and we'll also update you on the implications of that for the current continental response. I think with those few words, I would like to thank you all, and hope to see you again next week, same day at the same time. Thank you very much.